gave us some excellent statistics that needs to be injected into the discussion as well. So thank you all very much.
Thank you. Thank you,
Well,
Dale.
thank you.
Okay. Now over to this side of the room.
My name is Dennis Galan. I have a comment and a question. The comment is that I was very surprised that only one of the speakers made a distinction between legislation and morality, and that was Ms. Morris. And it seems to me that this is really a terrible oversight in questions like this. Any issue that involves, and there are many in Canadian society, that involves deep emotions around morality, we are a pluralistic society, and we need to learn to think differently about what the law should be and what my personal morality is, my personal or my group morality. And that distinction is not natural to us or to the populace at large. For example, the question was asked, raise your hands. It's a terribly unfair question. Do you mean, what do I think about euthanasia from a moral perspective? Or do you mean, what do I think the law of the land ought to be? It's a totally different issue, and unless our leaders and politicians begin insisting on that distinction, we're simply going to bring our own personal convictions into these sorts of issues when a totally different conversation should be taking place. That's my comment. My question is that, as far as I can tell, all of the panelists would agree that if we had permissive legislation in Canada, that there ought to be controls and safeguards. I would then ask you all, what ought those controls and safeguards to look like? And I suppose bring into that what those controls and safeguards are in other countries.
Okay. Who would like to... Juan, do you want to go
like
for
to
it first?
leap all over that one. First, I'd like to comment on your comment, which I think is so helpful. And I'm really inspired by some of our religious leaders who have taken stands. David Giuliano, who is the former moderator of the United Church, and he has said publicly, this isn't something that I would ever choose for myself, but it is not my right to enforce my decisions on others. Another a person in the U.S., an evangelist by the name of Daniel Lee, who comes from the Baptist faith, just said, this is what I personally believe. I think this is not something we should have, but it's not my place to stand in the way of others. So I think we do have some spiritual leaders and others who are trying to make that distinction, and I'm really proud of them for doing so, and really support your point. In terms of the safeguards, we've got two sources, particularly. There's some interesting legislation around the world, and a particular document that, if you're interested in this, I would recommend is the Quebec consultation document. And we haven't really talked at all about what's happening in Quebec, but in fact, they're leading the charge. They have committed to introduce legislation in that province provincially to legalize medically assisted dying, to introduce legislation by the end of June. So in 6 weeks, we could see legislation introduced there. And of course, it would have to go through the various readings that bills do go through. But potentially by the end of the year or next year, we could be in a situation where Quebec has legalized medically assisted dying under certain conditions. Now, the federal government has really opposed that position, as you can imagine. Quebec, though, has said, we're not trying to change the criminal code, which is, of course, federal. This is really a matter between an individual and their doctor. That's medical. That's provincial. We can change that. So that's the tactic they're taking. And because, as well as having control over healthcare legislation, it's also up to the provinces to enforce the criminal code, so thus decide who to prosecute. They can potentially say, well, we won't prosecute doctors if they have followed these conditions and guidelines. And there's a very interesting precedent because Morgentaler is, of course, from Quebec, and Quebec stopped prosecuting for abortions, doctors for performing abortions 12 years before the rest of Canada. So with that sort of background going on, we've got two So we've got this initial Quebec consultation report that laid out all the different jurisdictions, Washington, Netherlands, Belgium, Oregon, and what do they recommend, what are their eligibility criteria, and what safeguards are in place. You can download that document from our website. It's very interesting reading, so please do. And if you'd like my card with our website details, I'm happy to pass that out. So that's a great place to go to. Now, in Canada, we're most informed by two things: the guidelines set out by Carter in the Carter decision, the one with Gloria Taylor in BC, and the recommendations that came from Quebec. And they really address two key issues. One is who is eligible, and the second one is what are the safeguards. And we have quite a difference between the U.S. and Europe. In the U.S., we have very tight eligibility criteria. You have to have a terminal illness, which they define as having two doctors that say you have 6 months or less to live. In Europe, the criteria is more along the lines of irremediable suffering, an incurable condition, unbearable suffering, so that it's much broader than just that 6 months left to live. In Canada, when we were working on the Carter case, consulting with BC Civil Liberties to say, well, what do we want to bring? We said, well, we want to have a solution that would have supported Sue Rodriguez. You know, she was, of course, the one 20 years ago with ALS who took her case for the right to die to court. If there had been a 6-month clause, she would not have been able to get the support she needed to die. So we said we need to look more towards the European model than the North American one, because that 6 months is really artificial and arbitrary. And just because somebody faces the prospect of a horrific dying that's longer than 6 months doesn't mean they should not be allowed to have assistance. Now, the other part of it, so the eligibility criteria, is what safeguards do you want to have? Or, well, actually, the second part is what remedies do you recommend? Do you just recommend that someone can get a prescription, or do you say not only we should give you a prescription, but we should also, if you wish and request, give you voluntary euthanasia, so administer the lethal dose. And again, we have the North American, the pill only, the European, the administration of the dose, and both Carter and Quebec have looked towards Europe in terms of their decisions. So it's either the prescription or, as Carter says, if someone is not able to take the prescription themselves, then to have it administered. Then finally, getting to the actual point of your question, which was what are the safeguards? So there, at Dying with Dignity, we are actually just working on some recommended legislation that will be coming forward soon. But I can tell you that some of the things we're looking at is, for example, 2 physicians confirming a diagnosis, 2 witnesses, neither of whom stand to benefit in any way from the estate, so that we have, an extra control there. The 15-day cooling off period, so that it's a measured decision, persistent and consistent over time. Of course, one of the key things is that this is only something somebody can bring up for themselves. So you don't go in and say, Doc, my mom really needs this. No matter what's happening between you and your mother, this is something that you ask for yourself. And also that it's something that the patient brings up. So the doctor isn't suggesting, oh, by the way, did you know you could have this? But if a patient is saying, look, I really can't stand this suffering, I want to know what my options are.
Wanda, I'm just hoping you can wind up now.
And so let me wind up with that and recommend you go to the website, and I'll be happy to answer any questions afterwards.
Thank you. Would anyone like to respond to Wanda's comments?
Wanda's covered. I'm fine. Yeah.
Everyone's fine with, okay. All right. We're on this side of the room now. Go ahead.
My name is Donna Holmes, and I guess my question is, one of the statistics I've been reading is about the fear of people getting Alzheimer's, and where do people that have Alzheimer's, I've said to my husband now, if I get Alzheimer's, just shoot me. I don't want to be there. But from the criteria I'm hearing, even if I say now, I don't want to live that way, and a lot of Alzheimer's patients they're lovely people, but they're not who they were. They're in locked institutions for 20 years, and I don't want to be there. So where does this fit into this whole debate? Because there's probably going to be more of us with Alzheimer's than meet the criteria you're talking about. And I'm not sure who I'm addressing it to.
Okay. Dr. Heisel, would you like to take a shot at this?
Well, I'll take a shot. I think maybe that answers the question from before about why does it matter if I change my mind. If you start losing your cognitive capacity and no longer are, from a capacity perspective, legally capable of making your choices. And if prior to that situation you were to say something to your husband like, if this happens, go ahead and shoot me, then it happens, and he comes after you with a gun, and you say, no, I've changed my mind.
But I don't have a mind.
So I think part of the problem is that people do change their mind.
Right.
And the question is, and I think the fear that many people have, how locked in am I to a particular decision? Ideally, you're not, and you're able to change your mind, and your advance directive essentially indicates what your thoughts are at that time, and you can always override it, provided you're capable of doing it. And there have been examples, I'm sorry I can't cite where from, of situations where people were about to be assisted, even without necessarily their consent, under similar circumstances, stopping somebody saying, no, I want to live. Someone can come up with an alternative anecdote, but the point is, I would agree with the issue that these are complex issues, and I certainly don't pretend to have all of them. I'll say just very quickly, I too have a story about sitting next to somebody on an airplane. It was, actually many of them, but this was probably around 2000, 2001. I think many of us have our own personal reasons for being involved in this. One of them for me was that my grandfather died, and when he was in hospital, the physicians were actually advocating to my mother to stop transfusing him, saying the blood is just running right out, it's not going to, or going through him, whatever. And my mother was strongly considering it, and I reminded her of what his very clear position was, which was that it wasn't his decision, and that he should have every treatment available, and if it was his time, it would be his time. And so they did end up treating him, and he had additional time, but certainly not forever. So with that background, I saw the American Psychological Association put together a group looking at assisted suicide and end-of-life issues, and chose to get involved with that group. So on the way to the conference, on the airplane, I was reading a paper they'd put out on the issue, essentially saying in the field of psychology, most of us haven't done enough and we have to do more, which I'd agree. And the person next to me turned to me, saw what I was reading, and said, well, what do you think about this issue? And my response was, well, it's a very complex issue. And it looked like she wanted more of an answer, and I said, well, look, from my perspective, if somebody wants to die, we have to do what we can to try and enhance life. And before I could say anything further, she said, yeah, you're right, it's a complex issue. Turn back to the window, and that was it.
I should have tried that.
All right.
But
Thanks for bearing with me with that.
yes.
Okay, I'm going to move to the...
Can I just quickly?
Briefly.
Very briefly. I'll be much briefer. Just like physician-assisted dying isn't the answer to our financial cures problems, it's also not the solution to folks with Alzheimer's or dementia. But there are other solutions, and the really critical one is to have an advanced care plan so that you don't get antibiotics or other treatments you don't want, so that you aren't living for 20 years in that state.
Right. Question over here on this side of the room.
Hi, more of a comment. My name is Vanessa. And just wanted to quickly comment on what you mentioned a little while ago in terms of Morgentaler. It's funny that you bring him into the discussion of this and the slippery slope question that was brought up. Most people don't know that Morgentaler, when the courts struck down the criminal code monitoring abortion, the intent was actually to have abortion completely monitored and put up safeguards, and a lot of people in this room, I'm sure, even aren't aware that these safeguards were completely overrun, completely dismissed, and now we have abortion without any safeguards whatsoever surrounding it. So I hope, Mr. Blade, I guess this is more for your...
No, I'm aware of the
more
Supreme
directed
Court
toward
decision.
you than any specific person, but I hope that we're able to check out history and sort of learn from the past, especially when it comes to safeguards and potential hope to try and monitor something like that. Also, in regard to I guess just the second panelist from Mr. Valeriot really appreciated what you stated and the fact that you provided well-rounded, thoroughly researched information. Personally, I'm a lot more comfortable when it comes to looking at information surrounding this topic that has to do with information that's provided from a complete research-based background versus individual case studies. And again, Mr. Valeriot, I hope that if this issue is addressed in Parliament or in the courts, that our information is based on well-rounded, researched information versus individual case studies that seem to be generalized to the public and more or less forced on other people. I'll be bold and say that.
Yeah.
And then in terms of just the hands that went up, you have a panel that has two people for euthanasia, one person not so sure, and then one person that provided actual factual information. Of course, more hands are going to go up that are for euthanasia and assisted suicide than opposed to it. So
Don't worry, I'm not influenced by the hands.
yeah, again, I thank you for the position that you've had for on this issue in the past,
Yeah, yeah.
and I'm looking forward to seeing how you'll vote on anything in the future.
Thank you. Thanks, Vanessa. Yeah. Question over here.
Yeah, my name is Pat Wood, and as you can see, I'm in a wheelchair. But I just want to make a comment. I'm probably on the lesser support here at the moment, but I was a social worker back in the late 60s in Toronto. I worked in a chronic convalescent care hospital. Back then, we were training our staff to support life, to encourage the nurses to give as much support, palliative care as well with painkillers, this kind of thing. But we respected life, and we were trained, as a social worker, I was trained under a doctor. There was a Dr. Kubler-Ross at that time that had dealt with the various stages of dying. Dying is not just automatically accepting death. There are stages to it in most cases. And there are times when, yes, people want to die at a certain stage, possibly because of a depression, because of fear. There's various stages that normally a person passes through in the death process. And if we work with those people and help them and get the support from families, get the support from the staff, get support from doctors, many times those individuals, by the time they're ready to die, will have been able to accept the death, will have been able to reach a point where they have worked out possibly some of the issues that may have, with problems with families. Pain is not always the issue on which we should look at death. We should respect life. We should try to support people in life. And I myself was pronounced dead at age 5, was told then later, when, thank God, I came back to life, that I would never go to school or feed myself. That turned out to be false. I became a social worker, and I have definitely been able to feed myself. Up until a few years ago, I wasn't needing a wheelchair, and I'm certainly in one of the senior categories. I'm over the 65 age bracket. And yes, many of us will all be facing death at some point, but it takes more courage to live, in a sense, and even if that includes pain and depression and other things, than it does to say, I just want the plug pulled. Thank you very much.
Thank you.
Thank you.
Thank you. Okay, another question over here, and we are approaching, we are at 9 o'clock, and I'm thinking we've got 5 more minutes in the hope that those of you who are here would like to stay, knowing that we're going to wrap it up in 5 minutes. So, a question here. How many others are in line here? Just 2? 2 here and who? So we're going to cut the lines off, those 4 questions, and then we'll be finished.
Yeah.
Okay? So over here.
My name is Ann Bell. My question, I'm not sure who to direct it to. With the provincial push on home care, where would this come to? We're very lucky to have Hospice Wellington, and they do an amazing job and a hard job. But when people are encouraged to be looked after in their homes, and in some cases don't have a hospice bed available and may need to have their last days at home, when it comes to euthanasia and the family, what can we do, or what is the position of the panelists on how that would be handled? in the home setting versus a hospital or long-term care?
Dr. Heisel, sorry. Go ahead.
I'm not really sure how this would be handled, but in a sense, providing this either at home or in hospital should be under the same conditions. I don't think there should be a separate system that is administered in different ways because you're at home or in hospital. I think the sad part of this is that only 30% of dying Canadians can access palliative care. And this is 30 or 40 years after I started practice, and I remember when we started palliative care, we were going to ramp this up and try to deliver it to everyone. We owe this to people. Sadly, we owe it to them. And I don't think the government has corrected this, and I don't think it will be corrected until we actually stand up and say, look, we've had enough. We need hospice, we need palliative care, and we need other options at the end of life. I do think it can be delivered quite successfully at home, and there are some very wonderful, I know stories aren't always acceptable to everyone, but there are some wonderful stories out of Europe and from Oregon that show that this can be quite a lovely moment for a family to take in together.
Okay. Thank you. Anyone else? Dr. Heisel has one comment to make.
I'll make a very quick comment. I think that the issue of home care or the aging at home provincial strategy really was an attempt, is an attempt at dealing with some of the financial realities of the healthcare needs and really not having enough services available to meet them. Unfortunately, with many of the teams that are available, at least in my area, in mental health, in older adult mental health, the teams aren't complete, and what they're doing is still sort of playing catch up. So I think that's true of much of the home care services, and people who have had home care, CCIC, etc., come out to their homes are thankful for the services they get, but don't get enough of it. In terms of the issue, again, I agree completely. We need better palliative care. It's shameful that we don't have better palliative care. And I think from palliative care providers, you'll see that they're talking more and more about palliative care being introduced far earlier in the care process and not simply at the end of life. In terms of questions around euthanasia, currently it's not legal, and providers who come to the house wouldn't engage in it. I suppose if it were legalized, that would be something that potentially could be done in the home. But I think we also have to remember the flip side of it is the provider has choice too. And one of the barriers to legislation like this going through has been that the Canadian Medical Association has been opposed to it. So that's just to sort of share that information.
Okay.